Good evening, everybody. Thank you for joining us for tonight's webinar, Living with Multiple Myeloma, organized by the Florida Society of Clinical Oncology, or FLASCO. FLASCO is a member-supported state society that focuses on supporting and representing the oncology workforce of Florida. Together, FLASCO is the voice of oncology in Florida. Many of the individuals presenting and participating in this webinar are FLASCO members, and we are grateful for their support. My name is Dr. Sikandar Alawadi, and I'm an oncologist in the hematology department and the CAR T-cell therapy program of the Mayo Clinic in Jacksonville, Florida. My specialty is taking care of patients with multiple myeloma and some related disorders like Waldenstrom's macroglobulinemia and chronic leukemias like chronic lymphocytic leukemia. I will be serving as both your moderator and presenter for the webinar. Our oncology expert panel includes several distinguished guests from the state of Florida. Our oncology experts and I will discuss the mechanisms behind multiple myeloma and treatment options, as well as more individual-focused areas, including support for caregivers and patient advocacy. We'd like to thank Takeda for sponsoring this webinar and making it possible for us to share this important information. Before we begin the presentations, I'd like to let everyone know that this webinar is being recorded so that those who were unable to attend can view it at a later time. Also, your lines will be muted for the duration of the webinar. Toward the end of the meeting, we will host a question and answer session, and we encourage you to submit questions or comments via the on-screen questions box on your GoToWebinar panel. We will discuss as many questions as time allows. It's an honor for me to introduce our accomplished group of panelists for this evening's webinar. I will briefly introduce them now, but please read their impressive bios in the meeting materials that were emailed to you. The link to download the meeting materials is also in the handouts box on your GoToWebinar panel. Now, I'd like to introduce our panelists. Dr. Brandon Blue is a physician at the Moffitt Cancer Center, where he recently completed a blood and marrow transplant and cellular immunotherapy fellowship. His clinical interests include the treatment of plasma cell disorders and evaluation of patients pre and post bone marrow transplant. Dr. Blue's research interests include reducing health disparities and improving health outcomes for plasma cell dyscrasias. Our next panelist and a dear friend is Dr. Jose Sandoval-Sus, an assistant member of Moffitt Malignant Hematology and Cellular Therapy at Memorial Healthcare System in Pembroke Pines, Florida. Dr. Sandoval-Sus completed a hematology and medical oncology fellowship at the University of South Florida, Moffitt Cancer Center in Tampa, where his research focus was in prognostic and therapeutic aspects of lymphoid malignancies. His professional interests are in patient-focused care of all hematological malignancies, with a special emphasis in both indolent and aggressive lymphoid tumors. Also joining our panel is Alexia Zadok, a social worker at the University of Miami Health System Sylvester Comprehensive Cancer Center. Alexia Zadok completed her undergraduate and master's degree in social work from Florida International University. Since graduating, Alexia has joined Sylvester Comprehensive Cancer Center as the outpatient stem cell transplant social worker. Today, she provides clinical care and counseling and connects patients and their caregivers to cancer-related resources. After the question and answer, we will hear from our final panelist, Dr. Michael Diaz. Dr. Diaz joined Florida Cancer Specialists and Research Institute in 2011 and currently serves on its executive board and as the Assistant Managing Physician Vice President. In addition, he serves as the Director of Patient Advocacy for the FLASCO and on multiple work groups for the American Society of Clinical Oncology, or ASCO. He also serves on the boards of other organizations, including Community Oncology Alliance, or COA, and National Cancer Treatment Alliance. Thank you, panelists, for joining us to share your insight on the different aspects of living with multiple myeloma. Let's start off the presentations with my own presentation. What is multiple myeloma? Next slide, please. So all of us, every single individual, we have these cells that live inside our bone marrow. These cells are called plasma cells. The job of plasma cells is to produce proteins that builds up our body's immune system. These proteins are called immunoglobulins. These immunoglobulin proteins have something called a heavy chain and light chain. I think it's very important for us to know that all of us have these immunoglobulins present and the plasma cells in our bone marrow. But what happens is, just like any cell in the body can become cancerous, plasma cells can also become cancerous. And the cancer coming out from plasma cells is multiple myeloma. So when these plasma cells become cancerous, they can become damaged. They can start producing a much larger quantity of the same protein, the immunoglobulin protein, which they were supposed to form. This high amount of protein leads to these heavy chains and light chains, and this protein coming to our blood. As you can see in this slide, there is healthy bone marrow within our bones, but then when these plasma cells become cancerous, they can form multiple myeloma. These multiple myeloma causing plasma cells can suppress the healthy blood-forming cells within the bone marrow, can crowd up the bone marrow, and lead to some of the effects of myeloma, for example, anemia and a decreased immune system. Next slide. So it's important to understand that multiple myeloma is along a spectrum of disorders called plasma cell disorders. And generally, the precursor condition or a pre-myeloma condition is something called MGUS, or monoclonal gammopathy of undetermined significance. This really transforms into something called smoldering myeloma and then active myeloma. MGUS has about a 1% risk of conversion to myeloma per year. On the other hand, smoldering myeloma can have somewhere around up to 10% risk, depending on some genetic markers. Next slide. As I mentioned, these immunoglobulin proteins are produced by the plasma cells. It's important to know, because I think it's extremely important for our patients to understand what these proteins are, what these terms mean, because the more you know about the disease, the better you'll be able to follow it. So these immunoglobulins and light chains are produced by the plasma cells. Typically, we have something called IgG, IgM, IgA, and light chains like kappa and lambda light chains. So all of us have them. Next slide. The way to diagnose these abnormal proteins is that typically a blood sample is taken, the cells are separated out, and the liquid part of the blood, which is called the serum, is put on an electrophoresis membrane. And then electric current is passed through it, and the proteins separate out on the membrane depending on how heavy they are. All of us, this right side panel on the slide shows these proteins, which typically all of us have. Everybody has albumin, alpha-1 globulin, alpha-2 globulin, beta globulin, and gamma globulin. These proteins are present in everybody, and they separate out on this protein electrophoresis process. Next slide. What happens is that on the left side, you can see is the normal pattern where there is that albumin, alpha-1, alpha-2, beta, and gamma. But on the right side is what is the abnormal protein, or a case of multiple myeloma, where this gamma globulin has suddenly a much higher amount of protein, a peak of its own. This is what is the marker of the abnormal protein. And so the serum protein electrophoresis can pick up the M spike, which tells us how much is the disease and is used as a marker for response, marker for progression, etc. Next slide. There's also a test called immunofixation. Now, what immunofixation means is, and how it is different from the electrophoresis is, the protein electrophoresis tells us how much is the abnormal protein, but the immunofixation tells us what is the exact kind of that abnormal protein. So for example, on the top left panel, you can see that the abnormal protein bands are lying in the G, which is IgG, and the K, which is the kappa areas. So that particular patient's M protein or monoclonal protein or the myeloma protein is IgG kappa. On the top right panel, it is IgM kappa. On the bottom left, it is IgG lambda and a separate smaller IgA lambda. And in the bottom right, that darkness is only mostly in the kappa area. So the electrophoresis tells us how much is the abnormal protein, and immunofixation tells us what is the kind of that abnormal protein. Next slide. And then come the light chains. I can tell you just from experience, whenever there is any kind of numbers or math involved in medicine, it gets very confusing because doctors are traditionally not that good at math. So similarly, in the light chain area of myeloma, it does cause some amount of confusion. But let's see if we can try to make some sense out of it. So I mentioned that these light chains are present combined with the heavy chain in those immunoglobulin molecules. But in some cases, the light chains can be present by themselves, what's called free light chains, and they can be just floating around in the blood on their own. When the light chains are themselves the culprit, or so light chains are the protein that are being produced by the abnormal plasma cells, sometimes it may not be picked up on the SPEP or protein electrophoresis or serum protein electrophoresis. So to look at the light chains, we have to typically do an analysis called the free light chain analysis. So it's a separate test. There are two kinds of light chains, kappa and lambda, and then there is a ratio of the kappa lambda. What I can say is that when both kappa and lambda are normal, this top line which says kappa of 2, lambda 1.5, and whatever the ratio is, those are normal numbers. But in some cases, either one light chain can be increased or both can be increased. In myeloma, I can say that typically the problem is when one light chain is increased. When both of them are increased, that is not typically myeloma. That is typically could happen in kidney dysfunction or some other immunologic states. But in the setting of myeloma, typically one light chain is increased, and that's the one which is called involved. Now, the ratio is something that patients are frequently made aware of, and it's said, oh, your ratio is high, you should be treated. But in this example, you can see in the second row from top, where the kappa is 100 and lambda is 1. So the ratio is 100. But what if the kappa stayed at 100, but the lambda went down to 0.5? The ratio went up much higher to 200. But if you can imagine, the change was very small. The lambda went from 1 to 0.5, and that's not that big of a deal. So in myeloma, whenever we see an abnormal light chain, we do look at the ratio, but it's important to bring up to your doctors, what does that change in ratio mean? And typically, if both kappa and lambda are both increased, then the ratio stays normal, and that does not happen in myeloma. That typically happens in kidney dysfunction or, as I said, some other conditions. I hope this makes sense, but I would suggest if you do have any questions about it, do talk to your doctors, and especially when it talks about the change in the ratio, that is something that must be discussed with your doctors in detail. Next slide. So another thing that I really wanted to talk about was what factors to consider when selecting a treatment for myeloma. When you go online, you go through FLASCO, ASCO, American Cancer Society, etc., you will notice that there are so many options available, and it can be confusing for a patient to know exactly what is the right option. So we'll go through a few factors which, in my mind, are very important to consider and which can help decide what treatment should the patient be on. Next slide. So we do a bone marrow biopsy. Nobody likes doing a bone marrow biopsy. Nobody likes getting a bone marrow biopsy done, but unfortunately, it is important. And the reason for doing that is because it tells us how much abnormal plasma cells are present in the bone marrow. Typically, in the setting of myeloma, more than 10% plasma cells are present in the bone marrow. But importantly, the bone marrow biopsy also gives us whether or not the cancer's plasma cells have any genetic mutations, something called cytogenetics or FISH study. This is extremely important because it tells us if the patient's multiple myeloma is high risk or standard risk. And the treatment options can sometimes be a little bit different. So when I said what factors to consider, this risk category is extremely important. I hope that every patient is aware of whether they are standard or high risk myeloma. And if you are not, I think that is an important piece of information you should try to look for right away. It is also important to find out if there are any other, so the bone marrow biopsy tells us if there are any other causes of anemia or any other abnormalities going on in the marrow, but the risk category is extremely important. Next slide. It is also known, so historically, there used to be a different threshold for treating myeloma patients. It used to be this condition called the CRAB criteria. The C stands for calcium, R stands for renal or kidney disorder, A stands for anemia, and B stands for bone lesions. But a few years ago, about 5-6 years ago, these criteria were modified. There used to be something called ultra high risk smoldering myeloma, but now we talk mostly that patients who meet any of these 7 criteria should be treated as multiple myeloma. So now it's no longer just the CRAB criteria, but it's, for lack of a better term, the SLIM CRAB. And the SLIM CRAB stands for S for 60% involvement in the marrow. So if somebody has more than 60% plasma cells, then they should be treated. If the light chain ratio is more than 100, the patient should be treated. If the MRI is done and it shows there are any lesions, then the person should be treated. In fact, let me clarify, this LI is not the absolute light chain number, it is the light chain ratio. So more than 60% in the bone marrow, light chain ratio of above 100, MRI lesion, or the traditional CRAB criteria of increased calcium, kidney dysfunction, anemia, or bone lesion. So if somebody has any one of these 7 criteria, they are typically treated. I just want to also remind you that in a healthy adult, about 1 to 2% of cells in the bone marrow are plasma cells. If someone has more than 10%, that is the definition of myeloma. If someone has more than 60% or has any of these other criteria, then it's active myeloma, which should be treated. Next slide. I mentioned that there is a high risk and a standard risk. That's very important to know based on the genetic markers or mutations in the plasma cells. What happens is, and a lot of times patients will ask, well, doctor, was I born with this problem or did I acquire it at some time? Why did I get it? And unfortunately, we do not have a clear answer of why someone gets multiple myeloma, but we do know that whenever cancers develop, very frequently, the normal DNA that we are born with, that can undergo some mutations. And in that process of mutations or process of damage of the DNA, certain mutations are acquired which either make the cells cancerous and make them grow too much and form tumors, or lead to some other effects related to that cancer. So in multiple myeloma, there are 5 specific mutations that, if seen in the plasma cells, are associated with a high risk disease. And that's where I mentioned that these cytogenetic abnormalities, or something called the FISH test. FISH is important because that is a way of testing or looking for these abnormalities. And these 5 abnormalities are the letter T, which stands for translocation, so T414. That basically means that a portion of the 4th chromosome has cut off and gone and joined at the 14th chromosome. So translocation between 4 and 14, translocation between 14 and 16, between 14 and 20, or this dreaded mutation called the deletion 17p, which means that the small arm of the 17th chromosome is deleted or has a mutation there. So the deletion 17p, sometimes another abnormality called the p53 mutation, which is mutation of a gene present on that 17th chromosome, or there's something called gain 1q, which is the first chromosome has a long arm, and if that long arm is duplicated or there is an extra of that, those are all considered high-risk mutations. If a person has any 2 high-risk mutations, it is called double-hit myeloma. If somebody has 3 or more high-risk mutations, then it's called a triple-hit myeloma. More the high-risk mutations, typically worse is the prognosis. And other than these 5 basic abnormalities that I mentioned, everything else or presence of other abnormalities is still considered standard risk. So while myeloma can have other mutations, it is not associated with aggressive behavior or high risk. Slide. These genetic abnormalities, and again, this slide talks about a lot of other genetic abnormalities that have been associated with myeloma. This is a paper that was published just about last year. And what this paper did was it actually looked at some of these cytogenetic or genetic abnormalities in plasma cells and tried to say, well, you know what? How frequently are these seen in myeloma, and how does that matter to the patients? So for example, there is this mutation called 13q deletion, which is close to or just below the center of the slide. This 13q deletion can be seen in 45 to 50% of myeloma patients at the time of diagnosis. And while over here it says adverse, we now know that it's an adverse prognostic marker only if it is present with other things. If it's present by itself, it's not a big deal. Similarly, that 17p deletion that we talk about frequently, because that's a very dreaded mutation and it is associated with high-risk disease, that's at the bottom of the list, and it's seen fortunately in only about 10% patients at the time of diagnosis and is associated with poor impact. Next slide. When we talk about selecting treatment, I also want to mention that there is a variability in how this testing is done. Next slide. We recently completed a large study from a national data where we looked at about more than 1,200 patients and a lot of conventional cytogenetic testing and FISH testing, nearly 1,000 cases that were tested over a span of 18 years. And we just compared nearly 60 labs across the country. Next slide. What we found out was that the way this testing was done was very different. So while I'm saying to you that it is very important that you should know what is your risk category, standard or high risk, I'm also mentioning that the way this is tested can be very variable. So what we found out was there were, for example, labs that had done many samples, and there were many other labs that had only run 1 or 2 samples over 16, 18 years. And so you can imagine if a lab doesn't do the testing very frequently, their process or their experience may not be as much. Next slide. We also found out that there was a lot of variability within a lab and in between labs, even among labs, for what different abnormalities were tested. There are typically a panel of mutations that are tested within a disease. If a sample is, for example, sent to the lab at Mayo, they would probably test anywhere close to 15-ish different abnormalities. Some of them may be important, some of them may be less important, some of them may not be important yet, but we think may be important in the future. But what we found was that there were a lot of labs, there was a lot of variability in between labs and even within the individual lab. Next slide. We also noted that the different kinds of probes or different kinds of specific mutations that were looked at for any particular chromosome were very different. And I have a few examples here. There's something called translocation 1114. I mentioned chromosome 13 or 414. And we noticed that even amongst the labs, there were a lot of different ways the labs employed for testing. Next slide. Why this is important is I'm saying that there needs to be more standardization, but I think patients need to also be empowered, and they need to know what kind of testing was done, where was it done from, how frequently do their physicians access those labs, because I'm saying that based on these tests, treatments can actually be selected. But the good thing to know was that over the years, the number of tests, the number of areas that are being tested within the chromosomes, that has been improving. And so over time, I think we are testing for myeloma much more comprehensively. Next slide. There are other guidelines. There are other factors that are brought up in guidelines. And next slide. I'll talk about just maybe one of the guidelines that we have, which is what we use at Mayo Clinic. And this is something that is available to any patient. You can go to this website called mSMART.org, and you can access at least what we at Mayo feel the guidelines should be for treatment. And we keep adjusting them and updating them whenever new data comes out. So for example, this is just one of the guidelines where we say that if somebody is ineligible for transplant, they should consider a 3-drug regimen. I know we'll talk about treatment a little bit more in detail later, but 3-drug regimen is considered superior. The example I've used over here is a combination of bortezomib, lenalidomide, and dexamethasone, or daratumumab, lenalidomide, and dexamethasone. These are all FDA-approved regimens that I'm talking about. And then, especially for high-risk disease, after the initial treatment has been completed, maintenance must be given. We prefer bortezomib-based maintenance. I won't be able to go into the detail of why, but all I can say is that whenever new clinical trial data come out, about 40 of us who focus on myeloma at Mayo, we kind of sit down, look at that data, and try to see if our guidelines need to be updated. Next slide. Similarly, for patients who are considered eligible for transplant, you will notice that the initial branch point is that cytogenetic testing. We suggest that the initial treatment should be decided based on whether somebody has high-risk disease or standard risk disease. Sometimes these differences will be much more obvious, and sometimes they'll be a bit subtle. But generally, for those who are considered eligible for transplant, patients should be given induction therapy with preferably a 3 to 4 drug regimen, depending on risk category. Then they should consider going to the transplant, and after transplant, there should be some maintenance. What should be used for the maintenance, whether it is lenalidomide, bortezomib, or both, that's something you must discuss with your doctor. And also, I think I want the patients to be asking the question why a particular decision was taken. Next slide. Also, some other factors that we really importantly take into account are patients' kidney function, their age, their frailty index, or what's called performance status, what other diagnoses they have. So if somebody has diabetes, they may not be able to get too much steroids. If someone has peripheral neuropathy, they may not be able to get the drugs that can cause neuropathy, etc. Whether they have bone lesions or not, do we need to address that and give bone strengthening medications? And what symptoms does the patient have? Next slide. I can tell you that we consider, me and my other colleagues, all of us, we consider all of these factors to go into every single patient's treatment plan. So whether we need to treat early or late, what kind of an approach we're using, what are the factors of host, which is kind of patient, disease stage, disease biology, what are the risks, the high risk or standard, and how do we take that into account for treatment choice? And very importantly, I think you can see that the biggest piece of the pie is what is the treatment patient's choice. So we lay out the options for patients, and we then try that we help the patient make the choice which is for the best option. Next slide, please. So from that, I will actually end this first presentation, which was focused on what is multiple myeloma. And I think what is very, very important at this point is, as I'll just remind you that this presentation, if there are questions or thoughts or comments that come up, you should please type them up into the questions box. I'll read them, read as many of them as possible, and We'll try to cover as many of these questions as possible during the Q&A portion towards the end. And now I'll turn it over to Dr. Blue to turn on his webcam and to continue with his presentation on the role of stem cell transplant in multiple myeloma.
Hello, this is Dr. Blue. I am going to discuss the role of stem cell transplant as it refers to multiple myeloma. So the first thing that I wanted to discuss today is the phases of treatment when it comes to multiple myeloma. I wrote it down just to kind of make sure that people are very familiar with it, but I just wanted to just show people that there's 3 stages. I wrote it down as if you were a patient coming to clinic here at Moffitt Cancer Center. I would basically show you this and write this down for you kind of in the clinic. Is that the 3 phases that people typically do when it comes to multiple myeloma treatment would be induction, which is kind of the first set of criteria and treatment options that would get your disease under control. The next thing that we would discuss would be the stem cell or bone marrow transplant, as well as maintenance. Maintenance would be, even if the disease is under control, we do a great job with the first set of therapy, we do a great job with the transplant, you still need to be on some level of treatment, and we call that maintenance until the disease were to show itself again. So the next kind of step that people always ask me about is they say, well, can you tell me more about transplant? Can we kind of get into some of the details? And I wanted to discuss some of those details with you today. The first question that people always ask is, do I need a donor? Okay, I don't know if you can see it from this graphic here, but this is my terrible illustration, but hopefully the point will still get across, is that there's different types of transplant, okay? There's a transplant where this would be you, this would be a sibling, okay, or a family member. We call that allogeneic transplant, where you actually would need a donor. However, traditionally in multiple myeloma, we traditionally do what they call a autologous transplant, where there's no donor required. Okay, that's kind of the #1 question that we kind of always get is, do I need to kind of, you know, give everyone excellent Christmas gifts because I need a donor from, you know, Uncle Joe who is in the family? But really, we do reserve this donor transplant for some clinical trials that we have going on throughout the country. However, at this point, it is not considered necessarily part of the standard of care. However, the autologous or the self-given stem cells would be kind of the traditional way that we would proceed. And so if we were to come to Moffitt Cancer Center, just use that as an example, and we say, all right, you are a candidate for stem cell transplant after, again, we've done a great job of getting your disease under control with step 1. This stem cell transplant would be, like I said, step 2, okay? So what are the steps involved when it comes to stem cell transplant? #1, we actually call this apheresis, or collection of the actual stem cells themselves. And so what that process entails is we would put a special IV in your body called a catheter, okay? That catheter would be used to basically collect these stem cells. And what we do is we actually collect enough stem cells potentially for 2 transplants, okay? While we do that, we basically store these cells and we put them in a freezer, okay? So you're connected to a machine. We actually give you medications prior to that to help boost these stem cells that traditionally would be in your bone marrow. Now they're floating around in your bloodstream. So then you say, well, how do you collect them? Once we put that catheter in and we give you this medicine that has moved these stem cells from the actual marrow themselves to the bloodstream, we're able to just collect them by simply removing them from your blood, okay? We have a machine that is smart enough that actually kind of uses your blood and filters out the stem cells that we need. and still gives you back the remaining blood cells that you would typically have. So it's not like we drain you dry like a vampire. We basically just kind of take some of the blood out, remove what we need to as far as the stem cells. The stem cells go then into the freezer, and then, like I said, the rest of your blood cells would kind of come back to you. All right, that would be step one. And like I said, as far as this apheresis, we have enough of these stem cells collected and stored in the freezer for actually 2 transplants, okay? And so once they're in the freezer, they're good literally for decades. And so if you were to have a prolonged response, we could still thaw them out and they would still be viable, okay? Step 2, as far as the process involved with stem cell transplant, is the chemo, all right? So the chemo that we give, everyone gets the same name. Typically, it's called Melphalan, all right? That is the name of the chemotherapy that's given. It's a 1-day, 1-time chemo, all right? So typically, and some people may give it over 2 days, but typically it's a 1-time, maybe 2-time therapy or treatment that's given for the chemo, all right? And so people always think that the majority of the transplant itself is the actual chemo, but really that's not true. The chemo is given kind of as a 1-time kind of infusion in order to really suppress all of the cells that are there and really kind of clean up the bone marrow for any remaining cells. And then that brings us to really the third part, would really be the stem cell infusion. So what we do then is, after you've given this kind of large dose of chemotherapy and it's really kind of starting to work and do its job to kind of clean out your bone marrow, the next thing we need to do is to then rescue your bone marrow, because if we kind of get rid of everything, we need the grass to grow again. And how do we do that? We use those same stem cells that we have collected from you. We take them out of the freezer. Of course, we thaw them out, and then we reinfuse them. People say, well, how do we do that? The same way we kind of took them out, that very same catheter, okay, can be used to kind of take those stem cells, which literally would just be like almost like a bag of blood, it would look like to you, but it would be full of stem cells. We would give it to you, it would be infused. That would be your, bone marrow transplant day. Hopefully very uneventful process, okay? But then in your mind, you say, well, if the stem cells need to go to the bone marrow and you're giving them to me in the blood, how does that process work? And so luckily your stem cells are smart enough to know, once they get kind of exposed to the peripheral blood, they know to go back into the bone marrow, set up shop, and make new blood cells, which is the whole purpose of stem cells that they have been doing typically your whole entire life, okay? That process brings us to the next kind of last stage, which is called recovery, all right? So after the stem cells are done, after the infusion is complete, your blood counts will go down very low, okay? Your white blood cells, which is part of your immune system, will likely hit 0, all right? Your red blood cells, which is how your body gives oxygen, we don't, of course, want that to go to 0 because you need oxygen to survive, so you would likely need blood transfusions. You would also, the platelets in your body, the platelets are the things that if you were to cut yourself and hold pressure for a little bit and say, wow, I stopped bleeding, platelets act as that glue. Your platelets would also likely go to 0, but we don't want that to happen because of the risk of bleeding, so you may need a platelet transfusion, okay? And so the recovery process from actual chemo itself, as well as the stem cell infusion, we tell people typically it takes about 2 to 3 weeks, okay? Sometimes 4 in extenuating circumstances, but typically anywhere from 2 to 3 weeks. Because of course, this global pandemic, with it being the coronavirus and things happening, the immune system is playing an important part of kind of not being exposed to outside elements. So typically here at Moffitt Cancer Center, we would actually offer people to stay in the hospital in kind of like a lockdown section of the hospital, which would be kind of safe from outside influences, particularly the coronavirus. However, only God knows, but at some point, hopefully this will be lifted. And of course, pre-coronavirus, there is an option of actually not having to actually be in the hospital during the duration of the autologous stem cell transplant. And you would literally, relocate to Tampa if you're not in the area, and just come back and forth from the convenience of your hotel or a family member's residence, okay? I put a very important kind of next step or pre-step on this slide, and hopefully you guys can see this, is that prior to the apheresis or the collection of the cells, prior to the actual chemo being infused, that melphalan medication that I described to you, prior to the actual stem cells being infused, and of course prior to the recovery, would be what they call vital organ testing. Okay, we short term that VOTs. And the reason why VOTs are important is because we need to know, let's just say you're a 65-year-old person, that those organs really on the inside have really not been beat up over the last 65 years, either from chemo or from God knows what you've put in your body for that long period of time. So what we do prior to kind of purchasing a car, you kind of look underneath the hood. But prior to doing stem cell transplant, we basically want to make sure that you're a good fit and that you're kind of healthy and strong enough to actually do such a type of procedure. So we test, for example, your lungs, for example. We test your heart, we test your kidneys, we test a lot of your organs on the inside by this vital organ testing to make sure, of course, that you are, capable of tolerating such a treatment, okay? And the last thing that I wanted to just kind of discuss today, and of course there'll be more time for questions at the end, is besides the question that people ask me, the number 2 question that I always get asked is, what happens if someone skips transplant, okay, and goes from step 1 to step 3, okay? So typically, as I mentioned, if you are, traditionally young or fit and eligible for transplant, people will go step 1, step 2, step 3. But people always say, well, what if I don't want to do that, or what happens, okay? And so there's some data that typically we go by that say that there's about a double length of the time that your disease will be under control or in what we call remission compared to those who don't do the transplant. So for example, there was a study that was published that basically showed that people who went from step 1 to step 3 had about a 22-month period of time where their disease was under control before it kind of took off again. And those who had transplant had about 43 to 44 months, so almost a double period of time that their disease was under control if they did this autologous stem cell transplant. And so for most folks, of course, the median time that people get diagnosed with multiple myeloma are people in their mid-60s. So if we can double the time that their disease is under control, that's quality years that the disease is not causing kidney damage, that the disease is not causing bone damage, and that people can kind of live semi-normal lives while they move on to step 3, which would be the maintenance. And so that's kind of what I wanted to share with you guys today. And of course, I'm more than happy to discuss any questions, because I know stem cells transplant is a very kind of novel thing that people might not have very experience with. It's not glamorized on TV shows, so people may have never even heard of it, and there might be some fear associated with that. So I'll be happy to answer any questions and discuss it further when that time period comes. So thank you.
Thanks a lot for sharing your perspective, Dr. Blue. That was really very, very informative. And I really appreciate that you were talking to our patients attending the webinar just as you would talk to any patient who would come to your clinic. I think that also gives the patients some better perspective about how the myeloma care is done in day-to-day life. Next, we will hear from Dr. Sandoval Soos, who will turn on his webcam now and discuss relapsed refractory disease. Jose?
Good afternoon again, folks. My name is Jose Sandoval Soos. I'm one of the members of Moffitt Cancer Center, but in South Florida. My specialty is in lymphoid malignancies and multiple myeloma, as Sir Kander said, and thank you for the introduction, Sir Kander and Brandon. So and thank you, Flasco, for inviting me to join you this afternoon. I enjoyed very much so living with series, and I have been working with Flasco since 2017, trying to help all patients in Florida and their family members to understand more the disease processes and to be empowered by gathering more information about the disease, and in this case, of course, multiple myeloma. So again, thank you very much for having me, and thank you to Flasco for giving me this opportunity. My part of the talk is going to be focused on one of the most, I would say, complex parts of multiple myeloma. That is, how do we see as physicians, and how do we explain to our patients what happens when the disease comes back, and what will be the options to tackle this new challenge of having a relapse multiple myeloma. So let's get started, and please, next slide. Okay, so normally Sikander also touch base with this. Unfortunately, right now at this day and age, multiple myeloma is not a curable disease, meaning that it's not like other type of solid tumors that, after surgery, sometimes chemotherapy, sometimes radiation therapy, it will never come back again, or some other malignant hematology entities, like, for example, diffuse large B-cell lymphoma and so forth, that you treat the disease and perhaps it will never come back again. Even though we have made great strides in multiple myeloma, it's still not a disease that we can actually totally eradicate. So we cannot right now talk about cure per se. Sometimes patients have multiple myeloma that is controlled for years and years. And that's really, really very good. Sometimes with minimal therapy, which is most of the times, and sometimes with treatment holidays and periods of time where myeloma can be watched, and sometimes patients can get these treatment holidays and they're very appropriate. But nowadays, I mean, like you see in this in the title of my slide, I mean, treating multiple myeloma is a marathon. It's not a sprint, and it's certainly not a battle or a war that we have to win. It's a road that we have to walk with our patients and with the family members of our patients, and that's where, of course, we're here from. If you see the left side of my slide, we start at the very, very beginning of this plasma cell disorder, like Dr. Alawati alluded before, with this MGUS status, that is monoclonal gammopathy of unknown significance, going through smoldering myeloma, and then we arrive to the part of multiple myeloma, that is when I say symptomatic. That is mostly the part that Dr. Alawati touched base upon, the initial sort of what we call frontline therapy or first line therapy, and also the part that Dr. Brandon Blue also was alluding to, that is the part of transplant. That's when we try to put the disease on remission. That's when you see this part that is called the plateau of remission. And hopefully that can last several years. But then eventually, if a patient is healthy enough and lives long enough, the disease will come back. So this is the part that I'm gonna focus. So next, please, so we can see the animation. So if we can move forward. Okay, so I'm gonna focus on this part. However, even though what we tell you all that we have multiple tools and multiple options that are very effective for multiple myeloma, it is traumatic for a patient and their family members, to see that the disease is coming back, especially in the sense. Excuse me one second. I'm gonna charge my computer here. Especially in the sense that this will imply what is it? What should I expect, doctor? How fast do we need treatment? Do we need to start treatment tomorrow, next week, in 1 month? Also, what would this entail? Would it come sort of like more aggressive? Would it be more indolent? And what are the new potential? What is the length of the upcoming therapy? What are the side effects of those therapies? Would I need another transplant? What type of transplant would that entail? would I be a candidate for all these new medications that are being approved almost every year for multiple myeloma? So there's a lot of questions, and if you follow through those little sort of lightning rods that I put there, is just to understand and and be empathetic with our patients, that we know this is not easy when the disease comes back, and that's part of our job, to try to guide you through all this marathon that is multiple myeloma. So next slide, please. And again, I think, okay, again, we can go on in an infinite spot, sort of like treating our patients, trying to put the disease on relapse for as long as we can. We try, of course, trying to minimize the side effects, and again, waiting and hoping that the next relapse going to happen far enough until we have better things for our patients. But then again, this is very good, but we always are trying to strive for more. So I would put just some things that from my point of view and from my experience, what my patients have told me, and what my patients' family members have also, shared with me, is that, as of 2020, multiple myeloma patients can have more remissions and relapses, because indeed we have come up with very good and effective therapies. But I'm sure that we all want more, all of these three things. One, prolong the disease more and more and more, and of course, improve the amount of time that we are here for multiple myeloma, improve the survival related to multiple myeloma. Also, we definitely want to improve quality of life. I think, from my point of view, one of the main things that we are oncologists, is that for two main purposes. One of them, improve the survival of our patients that are suffering from multiple alignments, in this case, multiple myeloma, and also make sure we improve their quality of life, okay? And the other one is, of course, decrease the side effects of these treatments, because usually there are treatments that are given for a long time. I mean, one of the caveats there will be maybe to come up with treatments that we don't have to take forever. That will be great. And also, if we have to take the treatments that are ongoing, to decrease the side effects from those sort of quote unquote chronic treatments. And remember, one of those side effects that we usually we missed, and certainly it's there day to day, is the one that we talk about, financial toxicity. Because here in America, like I was telling one of my patients today, being a multiple myeloma patient is a 24/7 work. Aside from all the other things that are going on in life. And that's where also we're here to try to improve that for you, for all of you. And of course, the holy grail of this will be cure. And that, of course, is what we strive for. Hopefully one day we can tell our patients, this is definitely a cure, a disease that we can cure. So next slide, please. Approved medication, this is you're gonna see, and I did this in purpose, all right? The treatment algorithm for multiple myeloma, especially referring to the relapse refractory stages of multiple myeloma, is a little bit complicated, okay? And I would say that we have something that is called embarrassment of riches, that we have a lot of agents that are very active and combinations that are very active for multiple myeloma. And if we advance on this slide here to see the animation, we'll see that it's very convoluted, and that's where you need the guidance, and you need to ask your doctors about this, because this is like Alice in Wonderland, going down that rabbit hole, and we need to try to guide you in this rabbit hole. You see on the left side, we have all these great medications that have changed the natural history of multiple myeloma, called immunomodulators, that we also call it IMiDs. You certainly have heard, especially the last two of them, lenalidomide, pomalidomide, and the older one called thalidomide. Then we also have these very, very important type of therapies that are called proteasome inhibitors. That's what Dr. Alawadi and Dr. Blue was mentioning. For example, classic bortezomib, first of its kind, and then the newest kids on the block that are carfilzomib, and the latest one, ixazomib, that is an oral one, okay, which are very, very important on the treatment of multiple myeloma. Then if you see on the right side of the slide, the usual suspect, like I always tell my patients, steroids. Most of the time we will use dexamethasone with these medications, because actually they're not only very active to control multiple myeloma, but improve some of the one side effects of the other medications that actually improve the quality of life of some of our patients. And of course, we have the more classic chemotherapy sort of type of drugs that are called the cytotoxic therapies. The most important here in our armamentarium of therapies will be cyclophosphamide, or we also call it Cytoxan. And the one that Dr. Blue alluded to, that nowadays we're mostly using it for, in the context of a stem cell transplantation, that is called melphalan. And there's a lot of them actually that are coming down on the pipeline that you guys will be hearing more and more in the upcoming years. And also, we have a lot of other new medications. One that we use is not that popular. It's called histone deacetylase inhibitors. I just put it there because it is approved by the FDA. And then we start combining all of these treatments in a mixture of things. And then if we can advance, please, the slide. And we create all these combinations, thank you, that it becomes sort of like a tongue twister sometimes. RD, VD, MP, VTD, VCD, RVDK, you name it. Like I say, nowadays, the same, and this is an important principle for treatment on the relapse setting, like Dr. Alawadi said, in the context of relapse multiple myeloma, three drugs are better than 2 drugs, and this has been proven in multiple clinical trials. So whenever it's possible, we will use 3 medications at the time of multiple myeloma, when the multiple myeloma is coming back, when it relapses. And nowadays, what the new tendency is going to be using 3-4 drugs, not only especially in the frontline setting, but also on the relapse setting. So more and more, it keeps getting a little bit more complicated. So I'm going to spend a couple of time introducing to you, if you guys probably have heard about this, but introducing to you a couple of, some of them we have been using it for a couple of years now, but some others are only coming out to the clinic, okay? A couple of new agents, and if we can advance the slide, please. Oh, by the way, we also have a Cyborg-D, okay? That's just to tell you that we all come up with these, catchy names sometimes. But let's move ahead with the slide. So first of all, as you have seen, CAR T cells is one of the most exciting innovations in malignant hematology, certainly in some areas like acute leukemias and lymphomas, but it's coming around the block. It will come sooner or later to multiple myeloma. So CAR T cells stands for chimeric antigen receptor T cells, and I'm going to explain to you a little bit more about that in the next slide. Next, please. We also have this new type of therapeutic approach or strategy that is called BITE. BITE stands for, it's a little bit complicated of a word, but is bispecific T cell engagers or bispecific antibodies. And I'm going to explain what that means. Those type of agents have been already approved for acute lymphoblastic leukemia. It's the acute leukemia that is more common in kids and in adolescents, but it's also making its strides to multiple myeloma, and I'm going to explain to you that a little bit later. Next. Also, this guy over here, I was trying to, do a cartoon to depict more or less how it is going to work, but it's called ADC. It's meant to be antibody drug conjugate. And you see the little rocket there will be your antibody, and it has 2 payloads that will be the sort of like the white rockets next to it, okay? And it is an antibody that is attached to little payloads of small particles of chemotherapy. And I'm going to explain to you guys how that is going to work. And the last one is the one that we already have been using for a couple of years now, at least 3 years or more. That is what we call monoclonal antibodies. That if you see to the left in the ADC is the antibody without the chemotherapy. You see that it's a protein that is attaching to an antigen, meaning it's a protein. An antigen is a protein that is outside of the multiple myeloma cell. and it's going to attach there, and it's going to destroy the multiple myeloma cells by different mechanisms. I'm going to try to explain a little bit of how each one of these guys act in the treatment of multiple myeloma. Next, please. Okay, CAR T cells. Like I say, one of my favorite cards, TCL Lamborghini. So let me see how this, try to explain how this fancy technique works. So with a great effort since, the early 90s and late 80s, this effort to trying to empower or make a super powerful immune cell to attack cancer cells have been a sort of a holy grail, and they have been looking forward to do that for years, I would say decades now. And they done it, and first they have been somewhat successful. I would say it has changed the therapy of a lot of patients with really bad disease that are called acute leukemias, and also very high risk lymphomas with these type of therapies. And now the results of clinical trials that are early on, but the results of clinical trials indeed are very promising in multiple myeloma patients. They're not the same. Multiple myeloma is a different type of disease than lymphomas and acute leukemias, but indeed they're very promising, and I do believe that soon will be available for us in clinic, especially they're probably going to be approved in the late stages of the disease when patients have seen a lot of treatments. But more and more, we're going to probably move this technology more and more, early into the disease course of multiple myeloma. So let me try to explain this. Making this is called chimeric antigen receptor T cell. What we do is that we take a T cell is one of the soldiers or one of the components of that immune system that you have, that is your personal army. So T cells are one of the most powerful soldiers of that immune system, and it's the ones actually in charge of, defending us against cancer, including multiple myeloma. But sometimes cancer is very smart, and it can fool very easily your immune system. So what we do is that we take the T cells of patients through a process, as Dr. Blue was describing, of this apheresis process. We take that T cell, and then through a modified retroviral vector. It's a virus that is it's a portion of a virus that is totally dead, will not harm the patient. But what they do is that these dead viruses are very good, are sort of like transporting genetic material into a cell, okay? So we take a piece of sort of like a genetic material that sort of like encodes or it's programmed to express a protein, a molecule outside of that T cell. So we take, if you see where it says the making of a CAR gene, is that we take a piece of genetic material, of DNA, and we modify it in a way that we can put it inside that retroviral particle, or we call it vector, and then we take the T cells of the patients. We make a good selection of those T cells, and then in a very specialized process of bioengineering, we sort of like combine that particle inside of that T cell. Then we modify that T cell. So we sort of like make super T cells, and we introduce that piece of genetic material inside the T cells of the patients. Then we let the T cells divide and divide and divide and divide and divide, millions and millions of cells. Once they're ready, we bring them back to the patient and we put them back on their bodies, okay? So it's a same process of an autologous T cell infusion from the patient to the patient, but with certain modifications that will make these T cells stronger and more active against the multiple myeloma cells. So next, please. So if you see all this fancy scheme and all this tough explanation, is just to generate super soldiers that they're going to attack certain proteins outside of the multiple myeloma cells. Okay, so what they're going to attack? They're going to attack a protein that you guys, if you are in the myeloma forums and in all other information about multiple myeloma, you're going to hear more and more and more, and in fact, I'm going to talk about it in the next slide. It's a protein that is called BCMA, okay? And we're going to talk about that in a minute. So it's very important because it's a protein that is present on all plasma cells, on all the multiple myeloma cells, as far as we know. Okay, those are CAR T cells, and if there's answers about that, we can answer that a little bit later. Next, these BiTEs, or bispecific T cell engagers, or bispecific T cells. Let me try to explain that concept as well. It's also an immunologic therapy. Next, please. Okay, so basically, what it is another way sort of to deliver that quote unquote power of a CAR T cell, but without the CAR T cell. Okay, so doing it like sort of like an off-the-shelf kind of way. What it is that you bioengineering design some processes and so forth. They have created an antibody similar to daratumumab. Okay, that we're going to talk about. They have created an antibody that sort of has two arms to it, like Dr. Alawadi was saying. You know, they have an arm that will, in a way, sort of like grab the T cell. And it's going to pull the T cell in a way, and be explaining and sort of simplifying the process. But they're going to sort of like with one arm, they're going to pull the T cell, and with the other arm, they're going to pull the target cell. For this discussion, of course, the target cell is going to be the multiple myeloma cell, and they're going to put him in proximity, both the T cell that is your soldier, that is empowered to kill that cancer cell, and then the multiple myeloma cell, they're going to put it in proximity, so the T cell, so it can kill the multiple myeloma cell. This it is a very promising. It is, again, is already approved in acute lymphoblastic leukemia. The name of the medication is blinatumomab, but it's a whole different conversation. But this is a very promising way to treat multiple myeloma as well, and a lot of phase 1 and phase 2 clinical trials are undergoing right now. I would say, and Dr. Alawadi can correct me later, but I would say that this type of technology is a little bit lagging behind from CAR T cells, but it's probably going to be facing off very in a very short amount of time. They're very promising in a totally new, different way to approach the multiple myeloma at the time of relapse. Next. Okay, now going to antibodies. These are medications actually that are approved and that we use in the clinic very often, actually almost every day, for multiple myeloma patients in different stages of the disease. So starting with the one that we know the most and the one that we have been using the most in our clinic for the past 3 or more years are the monoclonal antibodies. We also call it naked monoclonal antibodies because they exert their power or their strength by binding directly to antigens or proteins outside the multiple myeloma cell, and then either activating the immune system to kill the multiple myeloma cell, or actually also killing the multiple myeloma cell directly, just by that. So I tell my patients it's like a missile, a very directed missile towards the multiple myeloma cell. There are multiple antigens or proteins that have been targeted with that, but the ones that have been successful up until now, the most successful up until now, has been CD38 that we find it in all multiple myeloma cells. And there are treatments that are approved already, and they're quite active. One, daratumumab, that is approved in the relapse setting for multiple myeloma, but also is approved on the frontline setting for multiple myeloma. Okay, very active medication, very useful tool for our patients for multiple myeloma in all stages. And the other one, the new kid on the block, that is also an anti-CD38 antibody, is called isatuximab. Okay, everything. Anytime that you see a MAB at the end of a medication, it stands for monoclonal antibody. Okay, so isatuximab is also an anti-CD38 antibody. It seems that it could potentially be binding or attaching to another part of the protein of that CD38, and it might exerting its activity in a different way. That remains to be seen, but indeed it's a very active medication. And right now it's approved when you actually combine it with another medication that is probably well known to a lot of our patients, that is called Pomalyst or pomalidomide. That was recently approved by the FDA just a couple of weeks ago. Then another antibody that is called elotuzumab. The target of this is called SLAM-F7, a little bit complicated, but it's also a protein that can be found. It can be found on the surface of that multiple myeloma cell, but also in other immune cells like macrophages that are also part of these soldiers of this immune system, and it's gonna try to act to destroy these cells as well. Important thing, elotuzumab is only approved to be used on the relapse setting of multiple myeloma, meaning when the disease has come back, and with combination with immunomodulator drugs, being either lenalidomide or pomalidomide. Okay, so next slide. And then the new antibody kit on the block, all right, it's called ADC, or next slide, please. Okay, so ADC, it stands for antibody drug conjugate. What it means is that, as I'm trying to, in this cartoon of this rocket with two missiles right next to them, is an antibody, let's say like daratumumab in a way, okay, but is attached to the antibody. You have small particles of chemotherapy, okay? So what it does, if you go down to the cartoon, and you see number one, this ADC antibody drug conjugate, it binds to a protein outside the multiple myeloma cell. Then that antibody, you see the little stars, that will be your chemotherapy, your payload, okay? That antibody is sort of like sucked in or absorbed by the multiple myeloma cell, and inside is destroyed. The antibody itself is destroyed, but the payload, okay, the chemotherapy is released within the cell, inside of the cell, okay? And that chemotherapy is gonna kill the malignant plasma cell or the multiple myeloma cell. It also has some activity it has some actions by activating the immune system as well. But the most important thing is that it does have some small particles of chemotherapy. The prototype medication for this is called belantamab mafodotin. I mean, belamaf, but every day they made these names a little bit more complicated just for us to try harder. But belantamab has been recently approved by the FDA to treat patients that have already sort of like that the disease has progressed after other antibodies like daratumumab, after lenalidomide or pomalidomide, and after things like bortezomib or carfilzomib. Okay, now it's a very active medication for this population, but if you combine it with some other medications, like for example bortezomib or Velcade bortezomib, it shows remarkable activity on this patient population. Okay, what is the target of that antibody? The same of the CAR T cells, that is called BCMA. So this medication is very promising. Again, it's very active on the disease, and there's a lot of more things to come from this antibody. Next. So as you all have seen, it's a little bit complicated. We have a lot of different options, if I might say so, to offer our patients in which the disease has come back. But the things that we as physicians, as specialists in this disease, we always ask to ourselves, and this is, I think the first one is one of the most important, all right? And we should convey this to our patients and to family members. So first of all, when the disease comes back, do I really need to treat this patient right away, or do I have to wait? Because one thing is, like I tell my patients, one thing is what we call quote unquote biochemical disease progression, meaning that your multiple myeloma proteins are slowly going up, right? Otherwise you're doing well, you don't have any one of those crab symptoms, not sleep crab, but crab symptoms, all right, or signs, but it's just the proteins are rising, but otherwise everything is good. So do I really have to treat this patient, and when will be the right time to treat the patient? Okay. Second of all, does the patient have new high-risk features? So in my practice, not all the time, but when the patient relapses, depending on how aggressive it is relapse, how fast after a transplant or after the first line of treatment and whatnot, most of the time I would say that I would do a bone marrow biopsy just to see if the patient has acquired some new mutations, like Dr. Alawadi was alluding to, that will potentially guide our treatment to a specific therapy, or that could inform us a little bit more about maybe how aggressive this will be in the future. And that's important also because there are clinical trials that might be focused on patients who have high risk features as well. Again, what drugs have been used in the past? That is something that is a principle of oncology treatment in general, but in multiple myeloma, being that we have all these variety of active medications, we really need to see what medications were effective for the patients in the past, for how long did the patient had a good response to these treatments, and for what medications the patient was obviously refractory or resistant to. So all these things come to a matter, okay? And again, it's very important to know that if we can, we should try to do at least a triplet of medications or 3 medications, okay? Also, it's very important, okay, not only how good were the response to the treatment, but also what were the toxicities in the past, okay? Because if there are some ongoing toxicities, we don't want to use a medication that have the same toxicities. Let me put you an example. If we know that our patient has a severe, like we call peripheral neuropathy, like grade 2 or above, usually above grade 2 peripheral neuropathy, we don't want to use agents that will give you more peripheral neuropathy. Say we don't want to use bortezomib again. If we were to have an indication to use thalidomide, that is an old medication, but sometimes it's useful, we need to be very careful with that. We need to be see what of our patients do not have a very good renal function and so forth. So again, how well is the patient? How aggressive can I be this patient? Not to give him a lot of benefits, but some harm, but not that much. And what is the bone marrow reserve? Because especially for clinical trials and for some other more intense type of therapies, we need to know this piece of information and some others. And of course, this is very important. What are my patient's goals? What are their values and preferences? And not only the patient, and on the family members as well, because everything, patient number one, but family members sometimes is incredibly intertwined to their goals and preferences of our patient. Okay, so we all take this into account to select the best treatment possible. Next. Some conclusions here for this, that new approaches that have worked before for our patients with relapsed multiple myeloma, to which persons were not refractory and did not have major side effects or ongoing side effects, should be tried and should be explored. First of all, we know that none of these therapies are curative, so all the options need to try sequentially. So we need to do rational approaches that have been studied systematically in clinical trials, okay? Avoid combinations, and if I don't have another better word to say, concoctions that are not proven to be safe and effective. We shouldn't try this. They should try sequentially in a methodic way that has been studied in the past. Okay, so however, there's not very good data to be for sure known that there's an optimum sequence or a regimen. We have some hints. I mean, for example, a patient has what Dr. Alawadi was saying, a translocation 1114. These patients tend to have a very good response to a medication called venetoclax, okay? Or if the patients still have a translocation 414, they tend to respond very well to proteasome inhibitors, things like bortezomib, carfilzomib, or ixazomib. Okay, so there's some things that they can help us to guide our therapy in that way. Of course, and this is very important for all our patients and family members, we need to encourage our patients to participate in ongoing clinical trials, okay? Less than 15% of patients with cancer in the United States participate in clinical trials. And in order to move the field and give better chances and better therapies to our patients, we need to encourage patients as much as possible to participate in clinical trials. And of course, there's always new challenges in relapse disease, some other more complicated scenarios, and there's a lot of new options for our patients. That is the message of hope that I want to leave you with today. Next. Most of all, treat the patient based on his or her values and preferences. And we already alluded this to, and this is extremely important. Well, next slide is just my goodbye slide. Thank you again for everything. I am part of Moffitt Cancer Center with my team. We are located in Broward, specifically Pembroke Pines, but we are big brotherhood here with Moffitt at Tampa. That is my alma mater. And of course, with every other oncology practice that is connected through Flasco. And thank you very much for this opportunity.
Thanks a lot, Jose. That was excellent and a very, very informative information. Considering that the field of relapsed multiple myeloma is so complicated and complex, I really appreciate that Dr. Sandoval kind of gave his perspective and also tried to summarize all this information. Next, we have Alexia Zadok, who I'll ask her to turn on her webcam, and then we'll be discussing patient assistance programs and caring for the caregiver, something that is an extremely important task. And by all means, we need to pay as much attention to the caregiver as the patient as well. Thank you, Alexia.
Hi, so as a hospital social worker, we tend to have very high caseloads. You may not meet all of us face to face, but it's very important that when you are receiving treatment, that you request to speak to your social worker. If you can't speak to them, you can always email them. But everybody who is receiving treatment has one assigned to them, and you might not know it. So it's important to connect with your social worker because they can have resources that you may not be aware about. A lot of the time, social workers in hospitals help patients when they're dealing with insurance issues, maybe even assisting picking insurances or applying for Medicare and Medicaid. Sometimes if we're not able to suggest the right insurance for you, we can refer you to financial counselors or to the billing department, and they can tell you which insurance companies will cover your doctors, your medication, and your treatment, or try to find one that will cover most of the things. I also help patients when it comes to ordering medical equipment that the doctors might place an order for the patients. So like a wheelchair or a walker, durable medical equipment. We also provide psychoeducation, counseling, and supportive interventions. What I do most of the day, though, is we help with a lot of financial resources. A lot of the times patients can have high copayments, even if you do have the best insurance, or going through this whole ordeal, and it's life-changing, and it can cause financial strains on families. So we help find financial resources that can also assist with paying bills and things like that. So there are many places that provide financial resources. I believe on the brochure there should be an attached page that has at least 10 logos for different organizations that I always refer my patients to. Additional information and resources can be found on the Flasco patient portal at patients.flasco.org to find assistance with medication, copay assistance, and financial resources. Sometimes it could be overwhelming going to the websites, especially when I provided a list with so many organizations that provide financial assistance. So what I always recommend is give them a call. Sometimes going to a website, you're just clicking through links and there's so much information that if you call and say, hi, my name is X, Y, and Z, this is my diagnosis, this is my age, this is my situation, they'll be able to refer you to grants and to programs that they have and services that are available to you. A lot of the organizations provide transportation. So sometimes they can arrange services to pick up your loved one and take them from appointments. Some of them will provide lodging. You can live, 2 hours away, or if someone gets a transplant and all of a sudden you have to stay somewhere that's 3 hours away near a different hospital, they can help arrange for hotels that are in the area that will provide either discounted hotels for patients and their family members or for free. The American Cancer Society has a lodging assistance program that's very helpful, and so does the Bone Marrow Foundation through Airbnb. Right now, because of COVID, a lot of our grants and organizations that we work with might be a little different than how they normally run, but if you call them, they'll still be able to refer you to organizations that can help. It's very important to take advantage of these resources because if you're proactive, it will help keep you on track for your treatment. A lot of times we'll have patients tell us, I applied for this grant. I didn't know it takes 2 weeks to a month for me to get approved. Now I don't have medication. What do I do? And before we always start the process, I always give this list of financial resources so you could become familiar with them and your families can. And they not only provide support to our patients, but also to the caregivers. Each organization has their own guidelines, which is why I say it's important to call them. Some of them go by age, some of them go by diagnosis, and some of them even go based on what stage of your treatment you're in. But if you give them a call, it's much faster and someone will answer the phone and tell you, this is what's available for you. So I'm gonna disclose this information. I personally was a caregiver for two parents who had cancer. So I know what it's like to be a caregiver and I know what it's like to need support. And I can say that caregiver burnout is 100% real. It's really important. I at the University of Miami at Sylvester, I used to run a caregiver support group on our floor. And it was really helpful because when you join a support group, you're able to connect with other people who actually understand what you're going through and who can relate to you. Sometimes it can be really difficult when you pick up the phone and you call your friend or your cousin and you're trying to vent to them about what you're going through, and then they turn back and say, oh, my kids left their laundry on the floor. Like, you need someone who can relate to you, who understands you and who hears you. And there's many organizations that have support groups, not just for patients, but for the caregivers as well. The American Cancer Society will connect you to someone who's experienced a similar cancer as you. And so it's someone who's relatable. The International Myeloma Foundation, IMF, and the Multiple Myeloma Research Foundation both have great sites that will connect you to support groups. Sometimes people, and I think because COVID is helping this right now, unfortunately, but sometimes people feel too scared to get in their car and to drive to a place and walk into a room full of strangers. But a lot of the support groups right now are actually online. So if you'd like to open up your webcam and come in virtually, you can, but if you'd like to call in, you can do that as well. So I really recommend looking into a cancer support group because other people can be in these support groups who can give you great advice and tips on how to go about this situation that you're in. Caregiving and being a caregiver and providing that support during this time can be very challenging. Many caregivers put their own needs and feelings aside to focus on the person with the cancer. This can be hard to maintain for a long time, and it's not good for your health. The stress can both have physical and psychological effects. If you don't take care of yourself, you won't be able to take care of others. It's important to delegate, create schedules, ask for help, but also to accept it. I know that as the caregiver, sometimes we feel no one knows my loved one more than I do. No one knows how they like their food cooked, how their clothes should be washed, how the bed should be made for them, how to handle them when they're upset. But it's important that if somebody else is offering help, it could be the hardest thing to do when you just want to take care of them and provide them support, to let someone else just step in and try to help. Figure out what are things that someone else can do that could provide assistance to you. If you have a teenager, maybe it's time to teach them how to do laundry. Maybe it's time to accept your sister's call who's saying, I'm going to the grocery store, can I get you anything? It's really important to learn how to say yes to help. And I know that can be something that's really difficult to do. Like I said before, creating schedules will also help you creating time for yourself. So it's important as the caregiver that if you can make 15 to 30 minutes a day, like in a pocket of time for you to go on a walk, to read a book, to step outside, it can make a huge difference. When I was a caregiver, I would make sure that every day, no matter what, I ate my lunch outside. Just like sitting outside, just in front of my door or in my backyard, just having fresh air and stepping outside of the walls that I'm normally looking at and running around made the biggest difference. Things that can help you manage your time and create more time for you. I think now because of coronavirus, a lot of us or some of us may have used something like Instacart or Amazon to help deliver your groceries. Well, that still helps you create time for yourself. Also, buying frozen food meals in Publix or in your grocery store in their frozen section can help give you more time, or meal prepping and then freezing your food. So in case you're having a really busy day, you don't have to feel overwhelmed. It's also a good time to figure out who in your life is your support system and who's there to help you and your loved one. If you can find someone else to volunteer to drive your loved one to an appointment, that creates a big help. But it's important that we also try not to neglect our personal life. I know once you're a caregiver, you can't even imagine thinking, how do you do something for yourself? Sometimes we can feel this guilt that comes over us. How dare I be happy? Like you can't even focus on anything but what's going on in your loved one because they mean the world to you. But you have to be 100% and you have to be strong and in a good mindset to be able to help others and to help your loved one. If you're not your best, then you can't help them be their best. During this time, if you have a congregation or a religious community, they can be very helpful as well. I know sometimes people like to keep this private, what they're going through, and it could be very difficult to share. You don't want to answer a lot of questions. But I've had some people who've reached out to one person in their church and said, hey, I don't really want to, talk about it, but I could use support. And then they've had someone else in their church who they've trusted talk to others, and then they've been able to drop off food and meals and volunteer to watch the caregiver maybe one day while the other person is working and help create a schedule. So that's another way to find additional support. Also, it's really important that we take care of our bodies, that we try to eat healthy meals, that we get enough rest, and that we try our best whenever we can to exercise. I have some caregivers who, when they would bring their patients into the hospital, their loved ones, they would say, okay, while they're here in their appointment, I'm going to take a 15-minute walk. And they would take the stairs. It's just important that we try as hard as it can be to create time to care for ourselves. Like I said, a lot of these organizations have support groups and ideas and resources that help caregivers and patients. So at Sylvester, I talk to the patients and the caregivers. More than anything, I'm always there with the caregivers. And it's important that you're seen and that you're heard too, because you're also going through this. And this is also, it's different from the journey of your loved one, what they're experiencing, but you also have your own story of what's going on with you right now. And it's okay to reach out for help. You need to. It's what's going to be best for you and for your loved one. So that's all I have to say. I'm very thankful to be a part of this. I hope that everyone takes time this weekend to look up these cancer support organizations and to give them a call, because they're extremely helpful and they're a lifeline. Thank you.
Thanks a lot for your presentation, Alexia. That was extremely helpful. And I really appreciate, because you were talking so much about the caregiver, which is frequently a forgotten aspect. But you know what? If the caregiver is not healthy and taken care of, the patient's care will be affected in a not so good way. So with that, we at least come to the end of these initial presentations. And now we're going to talk about a very, very important aspect of care, not only for myeloma, but cancer patients across the spectrum. So this is talking about disparities in cancer care. And this is a topic which is very, very near and dear to my heart, because a majority of my research, a big portion of my research is focused on understanding and trying to overcome these disparities, especially based on race and ethnicity among cancer patients, especially myeloma. We know that cancer affects each population differently, and minority groups in the United States bear a much, much greater burden for many cancers. The Florida Society of Clinical Oncology, or FLASCO, is actively fighting cancer disparities on many fronts. On your cancer journey, you can do your part by making sure you just ask. Help us narrow the gap. To learn more about cancer disparities in myeloma, please download the Disparities in Myeloma slide packet and Minority Cancer Awareness handout located in the handouts drop-down box on your GoToWebinar panel. With this, what we'll do is we'll now move to the question and answer portion of the webinar, and I really appreciate all those who have been sending their questions. I do have them pulled up in front of me, so I'm going to start asking these. What I'll do is I'll read out the questions, and then our panelists can decide who will answer, or maybe I can direct the question to them. In mind the time, what we'll try to do is not necessarily get multiple opinions on the same question, but we would like to get to as many questions as possible. We do have questions for the next 10 to 15 minutes, and then we will move to the final portion of the webinar. So panelists, I'm going to ask you to go ahead and please turn on your webcams, and then I'll start with the first question. The questions can be, yes, and then we can start answering these questions. I really appreciate everybody here. Okay, so the first question I have is, one of the listeners has asked, is it typical to lose your sense of smell after taking Velcade or Revlimid? I think that becomes an important question because this is one of the symptoms that can be seen by COVID also. So I understand if patients are bringing this up. And this is specifically from a patient who has been on Velcade for more than a couple of years, and then also is continuing on lenalidomide now for 2.5 years or so. So Jose, why don't you take that one on? Tell us what you think about the sense of smell in melanoma or treatment.
Thank you, Dr. Alawadi. I actually have not seen this side effect with either bortezomib, carfilzomib, or lenalidomide or pomalidomide. Is very important, like you said. I mean, one of the sort of like the harbingers, let's say, from acute COVID-19 infection could be anosmia, we call it. I mean, loss of the sense of smell. But certainly, I have not seen this side effect. Okay. One side effect that is totally not related to this, but it's important to know with bortezomib is actually stites. Okay, talking about near here, whatnot, that we usually don't tell the patients a lot, but definitely that's something that I have seen a lot. But certainly, yes. I mean, I don't know if Dr. Blue can comment on this, but yes, I have not. Me myself, I have not seen this side effect.
Sure. And I think that's excellent that you're bringing up that there are some side effects that can happen. So certain symptoms that could be either coincidences that they co-occur, or some side effects that could be very rare or uncommon. What I can say is I have not seen personally in all these years treating myeloma, I've not seen a sense of smell being lost, but I can say that myeloma-related neuropathy or treatment-related neuropathy can sometimes show up in weird ways. And there is something called autonomic neuropathy, which can affect some of our nerve functions. So I wonder if that has something to do, but I would suggest to whoever reached out that please discuss this with your doctors. Do not just assume that I'm on chemotherapy or drugs, so I'm supposed to have symptoms. Nope, if you have a symptom, bring it up. I'm pretty sure your doctor will address it, or you can see this specific subspecialist like an ENT doctor. Now, since you mentioned Brandon, Dr. Blue, I'm going to ask you a slightly different question which came up, which is somebody is asking about if you can comment on the incidence of secondary cancers from melphalan, or actually I'm going to go ahead and say secondary cancers in myeloma. So if you want to just quickly touch upon that, please.
Yeah, so most commonly, honestly, in the state of Florida, one thing that I tell all my patients, the thing to watch out for is skin cancers. So there is an increased risk of skin cancers in patients who have multiple myeloma. So that would be kind of number one. Number two would be, I think, the more kind of dangerous or traditional secondary malignancy that people think about is that there is a condition that is unfortunately associated with both the treatment of lenalidomide, which is one of the immunomodulatory medications, as well as with the stem cell transplant themselves. It can cause a condition which is known as myelodysplastic syndrome, okay? Typically, this happens over years, okay? And so this isn't something that is one of the, it's not typically one of the kind of short-term side effects of transplant. However, it can be one of the long-term side effects of transplant. And so it is something that we monitor very closely. And it is something that, you know, traditionally, it's not something that most myeloma patients have to worry about because, as I mentioned before in my earlier talk, that most patients, when they get diagnosed with multiple myeloma, they're either in their mid-60s or older. And so typically, you know, kind of long-term side effects, people likely would die of something else before that would be otherwise found. But that is something that we think about, and it is something that we monitor very closely. So yes, if you read about that, that is correct, and your doctor should be looking for that because that is something that is a potential concern.
Excellent. I think thanks a lot for bringing that up. I do want to remind all our patients that there is a lot of research showing that the mere presence of any one cancer increases the risk of subsequent cancers. So please, if you have any age-appropriate screening that is supposed to be done, please do it timely. And also there is recommendation to get plugged into survivorship clinics. Jose, you wanted to bring up something there?
So just a really quick point about this. I think it's also very, very important to know the following. There is extensive research that after the treatment with immunomodulatory drugs or IMiDs, after transplant, has improved not only what we call progression-free survival, meaning the time that we are without multiple myeloma, but it has improved overall survival. And there's a lot of things that Dr. Alawadi is actually an expert in doing this analysis. You know, things that are called meta-analysis have shown that yes, there is somewhat a small increase, it's true, small increase of cancers, like Dr. Blue said, myelodysplastic syndromes, or even acute myeloid leukemias, but the risk benefit, all right, over being on this maintenance therapy after transplant totally outweigh the potential risk of having these secondary malignancies, okay? So that's what I tell my patients. Even though it is real that there's somewhat an increased risk, it is on your best, you know, on your good, and the benefit is on you to take that type of immunomodulatory drug. That's all I have to say about it.
Excellent. No, that's a very good point. So with that, Brandon, I'll ask you another question related to maybe transplant, and currently we are in the COVID era, so life is different, obviously. So one of the patient or caregiver is asking, could you please discuss revaccination and whether myeloma patients will be able to have a COVID-19 vaccine when one becomes available? So I think it's probably good to put this in perspective of post-transplant vaccination, which happens. So do you want to touch upon a little bit about the post-transplant vaccine? And in fact, I'd be interested in finding out, what are you guys talking to patients about COVID-19 vaccine when it becomes available?
Yeah, so you know, right now, typically the typical schedule for so I guess first off, I'll start off by saying that for those who aren't familiar, that during the stem cell transplantation period, a lot of the immunogenicity that you've kind of acquired over your lifetime from vaccinations will be lost, okay? Meaning that there's different levels of actual viruses that are stored in your bodies. We call those titers that happen from the vaccination process that you had likely as a youth or even sometimes as an adult. Those will be diminished as a consequence of autologous stem cell transplant. And so typically post-transplant, there's a revaccination schedule to kind of bring your immune system kind of back up to par with those different levels or titers of those different viruses. And typically there's 3 months, 6 months, 12 months, 18 months, and then 2 years. Typically there's a full schedule and a list of vaccines that we give patients kind of during the transplant process. However, a lot of the vaccinations that we give will be what they call killed or inactivated vaccines. We typically don't recommend anybody to kind of go out and do live vaccines because live vaccines do have the risk of kind of someone having kind of the full-blown disease, the risk is just higher. And so, you know, I think right now, honestly, I think the data on any COVID vaccination is premature at best. You know, so I really don't know, and I haven't heard any kind of updated data. So I think that the transplant population for sure is at risk. But as far as kind of weighing risks and benefits of kind of what the information is out there, it may be a little premature because, like I said, I haven't heard any of the latest and greatest on those. But I will say that vaccination is always something that's encouraged, even though sometimes because of these plasma cells that are the problems, it may not actually mount a response, unfortunately, but it is something that is encouraged.
Perfect. Thanks a lot for sharing that. So I know we have very limited time. There are a couple of questions which are asking about MRD. So if it's okay, I'm just going to quickly give a couple of words about MRD, or minimal residual disease testing. Actually, in addition to that, some of you have asked about specific clinical trials and said, well, is this particular clinical trial good or not? Is that clinical trial good or not? And then some of the patients have asked specific questions related to their own care. If it's okay, what I'm going to suggest is that we're not going to be able to take any personal individual questions, but one of the important resources for all of you is to try and seek out another opinion. If you have questions, or if you're not getting the right answer or the answer that's satisfying you, please seek out another opinion. There are a lot of myeloma experts in your area and anywhere, and with COVID, just like Alexia mentioned, our current medical state has given us the opportunity to do remote consults also. So please consider doing that. As far as specific clinical trials are concerned, there are many a clinical trial. The last I checked, more than about 700 or 800 active clinical trials going on in the country for myeloma. Please seek out the clinical trials. It's important to consider them, discuss them with your doctor, discuss them with experts. From the minimal residual disease standpoint, all I can say is that right now the goal of treatment is not to keep treating till we get to MRD negativity, but if someone does achieve minimal residual disease negativity, that is a superior prognostic sign. There are ongoing large clinical trials which are specifically asking a question, well, if somebody's MRD negative, can their treatment be stopped? Or if somebody's not MRD negative, can their treatment be continued or changed to get them to MRD negativity? Those questions are not yet fully answered. Brandon, go ahead. You had a point there.
The only thing I just wanted to say too, and encourage people that are listening to remember, is that, you know, the 3 or 4 people on this kind of panel for sure are experts in this field, but also know that there are institutional variations, okay? Meaning that you may hear something and you say, my doctor never told me that, or that's not the way we did it, or something like that. I just wanted to just encourage people to just remember some of it is not what we call data driven, meaning that like there's not what we call concrete evidence that the way they do it in this place is better than the way they do it in this place. And so sometimes there's differences and subtleties and those kind of things. So I just wanted people to remember that, just because that's super important as we discuss some of these very kind of personal questions that come up.
Excellent. Alexia, I do have a quick question for you. If you feel, is there a consolidated kind of list of resources that the patients can go to? You presented such great information. What do you, of course, you would probably give a booklet or a handout to patients who you see, but what can our other patients who are not able to, let's say, come directly to you or get those resources, what should they go to?
Honestly, that brochure that I attached, that's what I would go to. Just look up each organization, because I recommend things to patients after I get to know them based on their circumstance or what they're going through or what they specifically need. One organization might help with transportation and lodging, and one might help with financial assistance. One might just help with medication and co-payments. So it really depends what the patient's going through, but that's why this page of the cancer support organizations is so important. But you can also just Google like financial assistance for multiple myeloma, and then it'll take you to probably one of these sites. But each of these sites have a list of financial support, financial assistance, support groups, and they're all very helpful. I think for financial support and for insurance information, Cancer Support Helpline, it's one of the best if you're a little stuck and don't know what you're doing in terms of picking a insurance company, and they'll help you create a financial plan. So they're really very helpful. So it's based on that. But like I said, one more thing, just join the support group. join a support group because other people can recommend to you and share their experience with you, what they're going through, and may tell you something different that may make you ask your doctor about something like Dr. Blue said.
Yeah,
so.
Excellent. That was such a great advice. Please join support groups. Everybody keeps saying patients need to be empowered. I think gaining the knowledge is how you can empower yourself. So with that, we're going to wrap up our Q&A session, and I really want to thank our panelists for taking the time to answer these questions and taking time away from your family, your loved ones, and spending time in what all of us like to do is spread the knowledge and improve the outcomes for patients. We will now wrap up the webinar with a presentation from Dr. Diaz on patient advocacy.
Hello, I'd like to welcome you to the advocacy portion of our Flasco Living with Cancer series presentation tonight. My name is Michael Diaz, and I'm a medical oncologist and hematologist. I'm the Flasco Director of Patient Advocacy and a past president of Flasco. I practice medical oncology and hematology in St. Petersburg, Florida with Florida Cancer Specialists. And we're here today to talk about something that's pretty near and dear to my heart, and it has to do with patient advocacy. And so first of all, I'd like to start off more from the big picture perspective. I've had people tell me in the past, well, Mike, talk about advocacy. Tell them what it means. Well, I looked up the definition of advocacy in the dictionary, and all it says is to advocate. Very helpful, huh? So let me just explain. So advocacy, as far as I'm concerned, yeah, it's a general concept, but it means to advocate for, which means you're trying to do something to benefit somebody, whether it be yourself or somebody else. In fact, you all being here tonight to educate yourselves means you're advocating for yourself in the form of education, educational advocacy about a condition that might mean something to you or someone you know or care about. So yes, there's educational advocacy. Your doctors will also most likely advocate for you whenever they're fighting insurance companies to get scans or medications or therapies or testings approved. We really don't get paid any money to do that, and that's we either have to hire staff to do that or we do a lot of it ourselves too, but we're advocating for you. The way, and there are many other ways besides education. You can advocate for family members. You can help assist with certain components of their care, and all that is advocating. There are lots of ways to do that. The main way that I like to advocate for my cancer patients, because that's one of the reasons why I love being a doctor. In my free time, which is not a lot of, but I do spend a lot of time doing it, is I advocate for my patients when it comes to healthcare reform. One of the things that I noticed as I was going through my training as a young oncologist is that it didn't seem to me that there were a lot of healthcare providers involved with the policy decision-making process that would impact patient care, patients' health care, or their access to care. And one of the things that I've been doing since I've been practicing medicine for a little over 15 years now, I've been getting more and more involved with advocating for healthcare reform so that patients have access to affordable quality healthcare that's close to home. I'm a firm believer that we have enough resources in this country. There's no reason why people shouldn't have to spend their life savings or refinance their house just to get their cancer care. I think it's ridiculous. I personally think that the system is flawed in a lot of ways, and I think that there are a lot of people who are getting a disproportionate share of the resources, and those are not the patients, and I personally don't think they're the providers either. So that's one of the reasons why I'm involved with healthcare reform. And we do it in a lot of ways. I work with organizations of like-minded individuals, whether it be other oncologists or pharmacists. We have organizations. We work to advocate here in Flasco, mainly at a state level and also at a national level. But I do work with other organizations for synergy. And it all has to do with in understanding the healthcare system, which is extremely overly complicated. It needs to be fixed, but it's what we have, and we have to understand it to understand where the problems are so we know where we can fix things. So if we need to, instead of guessing, we will perform studies or commission studies to be done to better understand the little nuances of how potential things are impacting patient care or access to patient care. And then we also spend a lot of time educating our elected officials on this process, whether it be local in Tallahassee, whether it be going to DC, which we don't do a lot of traveling now, but I previously I would go to DC at least twice a month to help educate our elected officials there. We have to network a lot with Health and Human Services as well as Center for Medicare and Medicaid Services. And at a state level, we have to work a lot with the governor's office, the insurance commissioner, as well as Florida Medicaid for a lot of patient issues. And just to give you an idea of how effective you can be sometimes, for those of you all that aren't aware, about 4 years ago, the previous administration attempted a demonstration project that we will call the Part B Medicare Demonstration Project. And they thought, oh, we're going to save money, we're going to reduce the cost of care. And unfortunately, all it would have been doing was restricting access of care to possibly 50 to 75% of Medicare patients across the country, because it basically refused to pay for the more expensive treatments. Well, if you have cancer, you know that a lot of the time, the most effective treatments are the more recent treatments and are going to be the more effective treatments. Well, they were going to try to encourage you to use more generic medications. Well, the generic medications in cancer care are over 10 or 15 years old, and they're fairly outdated and not usually as effective as the newer medications. So it would have negatively impacted patient care. We went to grassroots across the country. We had to have all of our patients contact their representatives and their senators and tell them that they needed to shut this down. We were very successful in that it never took place. In fact, the following year, I went to meet one of our senators' healthcare aides, and she said, you don't need to introduce yourself to me. Because of you, I had over 3,000 emails in my inbox. My email was locked. My email account was locked for several weeks. She said, you did a great job with that. The senator wasn't listening to me, but when he saw how many people were concerned about this project, he said he realized he had to listen. So we can work together, and we'll talk more about that. I would like to move the discussion onto a more timely, more relevant, more current issue, which is known as pharmacy benefit managers. And most people aren't aware of even what a pharmacy benefit manager is. And just to give you a little background, the pharmacy benefit managers are who your insurance companies hire to manage your oral prescription benefits. They started off as just claims processors back in the 80s and 90s. All they would do is process insurance claims for oral medications. Well, over time, they evolved, they coalesced, they merged to the point to where there are essentially 3 pharmacy benefit managers that manage the oral prescription benefits for nearly 80% of all Americans. That's a lot of control and influence. Well, what happens when you have this control and influence? Stay tuned, we'll talk more about that. But these pharmacy benefit managers are so lucrative from a business perspective that they are merging with the top largest insurer companies in the country. In that one of the largest pharmacy benefit managers, CVS Caremark, recently bought one of the nation's largest insurance companies, Aetna. Well, 3 of the largest pharmacy benefit managers are owned or own some of the top 4 largest insurance companies in this country. So there's a lot of vertical integration going on. And it's because this component of healthcare has become so profitable. It's like, well, why has it become so profitable? Well, these pharmacy benefit managers, and more we're learning about this. In fact, this gets us to something that's near and dear to my heart, the price of drugs. I think the price of drugs are crazy, they're astronomical, they're very high, and it's difficult for patients to get their care because these newer medications and treatments cost so much. Well, studies are showing that when it comes to brand name drugs, we don't even talk about generics, it's a lot more complicated. Brand name drugs, probably well over 50% of the cost of any drug, whether it be oral drug or IV drug, over 50% of that is going to somebody else as a rebate. Yes, over half the cost of drugs. So if you're on a drug that costs $1,000 a month, over $500 of that is going to a rebate in somebody else's pocket, not the pharmaceutical company's pocket. So a lot of people like to complain to the pharmaceutical companies about drug prices, and I'm not letting them off the hook. But when I meet and I talk with a lot of the senior national executives in pharmaceutical companies, and they're aware of my stance that drug prices are too high and they need to get them under control and they need to do something about it. But part of the reason why the costs are so high is because of these rebates that are given out. Well, these rebates are from the drug companies, but they have to be built into the cost of the drug. And one of the nation's largest recipient of rebates are these pharmacy benefit managers and or insurance companies. Yes, the US government via Medicaid and the VA healthcare system, they get some rebates. And they are a decent sized percentage of those rebates, but nowhere near as large as the rest of the rebates. In fact, some studies are showing that well over $150 billion a year in 2019 dollars was spent on rebates. And that's one of the reasons why the cost of drugs are so high. And when I talk with the senior people in pharmaceutical companies, they are somewhat traumatized after they have discussions with these pharmacy benefit managers, because they have to talk with them and set up contracts before the pharmacy benefit manager will make their new medication available to the lives that they cover. And this is a typical comment I hear about that a pharmacy benefit manager would tell a pharmaceutical company. Wow, we really like that drug, your new drug. It's great, and we'd love for our patients to have access to it. But they need to know that we're working for them. So up front, we want you to give us a 10% discount off of the price so they can see we're working for them. And then after they've paid their copay, and after all the claims have been processed, on the back end, we want a 50% rebate. Otherwise, they will not even know your drug exists from us. And so these guys, they want their drugs to be available. And like I said, 3 of the largest pharmacy benefit managers control nearly 80% of the prescription benefits. If you don't let them have what they want or some version of it, your drug's not going to see a lot of patients or not even have the possibility to be used for a lot of patients. So there's definitely an issue with the rebate system going on, but also on the other end, the pharmacy benefit manager will also go after the providers. When I say the providers, the pharmacists, or in the case of cancer patients, if the cancer doctors are providing the drug, even the oncologist. They like to come back to us about months after the transaction occurred, i.e. the prescription was given, and they'll just come back and say to the provider, either the cancer doctor or the pharmacy, and say, yeah, you owe us 10% of all this money. And it's like, why do we owe you 10%? So, well, you didn't meet quality measures. And this is exactly what was told to my practice. You didn't meet quality measures. It's like, we didn't know that there were quality measures. They said, well, you're correct. There's not any oncology or cancer specific quality measures. So, we looked at the cancer patients that you're taking care of, our cancer patients that you're taking care of, and we looked at their adherence rates to blood pressure medications, diabetes medications, and cholesterol medications. And well, they were all perfect and they were adhering to their medications. So we couldn't use that data. So we looked at the entire Southwest Florida regional adherence rate to blood pressure medications, to diabetes medications, and cholesterol medications, and we applied that to you. And because the compliance rate in Southwest Florida is not very good, you've got to pay this penalty. And my people know that if we don't pay this, what's called a DIR fee, direct and indirect remuneration fee, then we get kicked out of network. We can't take care of our patients. And trust me, if we can provide the oral medications to our patients, they will have much better patient care than if it's provided by some third party specialty pharmacy that's nowhere near here, that knows nothing about patients or patients' care. So we do what we can on our end to try to sustain those fees. But those are just examples. Now, that's how they affect the business end of thing. That's how they affect the pricing end of thing. But in order for these pharmacy benefit managers to make more money and to steer more traffic towards certain products, they develop these formularies. And these formularies are, I guess you could say, their versions of preferred drug lists, and that drugs that they like, and some might even say, yes, that might be the appropriate indication for the drug, but are they getting higher rebates on this drug, and that's why they like it or not? We don't know. All that information is privileged and considered to be proprietary. But they have these formularies, and we're seeing perfect examples of how these formularies that they're trying to implement on cancer patients, they don't really work. You have cancer, you know that you may have other unique healthcare conditions, and it's not like there's a plethora of medications with which you can choose from, which some might consider to be your best treatment option. Why? Because different medications have different adverse side effects, and some may have an adverse side effect profile that may be detrimental to you given your unique health characteristics, or may not be better for you given your unique cancer. And so it's very difficult to say that just because I have cancer and it is cancer type X, that you should always start off with this one medication that these pharmacy benefit managers are saying you should start off with. And I can give you a perfect example. Let's tie it into patients. One of the things that we do is that we collect what's called patient PBM horror stories. And I do want you to know, if you have had any of these horror stories, as I will be talking about in a minute, please type in the little text box your name so that we can, and the best way to reach you so that we can reach out to you at Flasco and get your horror story recorded. We do this at the Flasco level. We do it at a national level. I do it with a national organization I work with called Community Oncology Alliance. If you go to pbmabuses.org, that's P as in Paul, pbmabuses.org, you can see, unfortunately, volumes of horror stories that have resulted from these pharmacy benefit managers negatively impacting patient care. Just to give you an example, getting back to the formularies that we were talking about, we have several examples that have even happened here in Florida where a patient with a condition and other cancer and other medical conditions, for example, like bad kidney disease, should be getting, if you look according to routine formularies and what's considered to be the #1 line of therapy, a medication that its #1 side effect is that it can impact the kidneys. Okay, well, one of my partners saw this patient and realized, wait, this patient needs this medication. It could impact the kidneys. They have bad kidneys. Then maybe we need to start them on the second line medication first, period, and avoid this potentially more dangerous one. They sent the patient to a local cancer center of expertise, and their specialist in this cancer said, yeah, you can't have that #1, that first drug, that first medication. You need to start off with the one second on the list because it could hurt the kidneys. Well, it took the pharmacy benefit manager over 2 months to approve the medication because it was denied because it wasn't #1 on their formulary list. So we have several examples of where they can delay access to timely care. We even have examples nationally of patients just dying while they're waiting for their medication to arrive. An unfortunate example of a patient who waited 9 weeks for a routine metastatic breast cancer medication to arrive, but the pharmacy benefit manager fought with the provider for so long, the patient gave up after 8 weeks, went into hospice. The medication showed up just after that, but the patient was too weak to even take the medication. We have other examples of where the pharmacy benefit manager, I have 2 examples in my practice, not with me, but with 2 of my partners, of where the pharmacy benefit manager actually said, no, we know this medication is front line and is the first one that's listed to be used, but we think the patient should have surgery first. And in both instances, even the surgeon and the medical oncologist said, no, surgery is contraindicated in this patient. They said, well, no, we think the patient should have surgery first. So they're making a medical decision without even seeing the patient. They're making a medical decision without a license to practice medicine. And that's one of the things they're doing to save money and to help their bottom line. These guys are businesses. They took an oath to their shareholders. They did not take an oath to patients like the doctors did. And so if you have a horror story, please type it in on the question box so that the people from Flasco can contact you, hear your horror story so we can get it documented. We need to have these documented. And part of the reason why is that we are working on trying to reform the healthcare system as far as these pharmacy benefit managers are concerned. We're working both at a state level and at a national level. To give you an idea of what we've been doing at a state level, in fact, we've been coordinating with other healthcare advocacy organizations, and we attempted to have legislation passed last year for pharmacy benefit managers it would have held and made sure there was transparency as well as accountability. Because right now there's no transparency. I was in DC a couple of years ago and was talking with some key staffers on both the Senate and the House, and they said, yeah, the pharmacy benefit managers people were up here yesterday, and they were lighting their hair on fire saying, oh no, we can't be transparent. That will disclose proprietary information. We won't be able to save money. There's no way we can be transparent. Well, you know, this is healthcare. Everybody needs it. And if you have to be that transparent, then is there a reason for that? So we want reasonable transparency and we wanted accountability. And unfortunately, that bill did not pass. It did not go up for vote in the House or the Senate, but we will be working on that again for next year. And that's one of the reasons why I want to grab your attention. We will be working on that next year, and we will need your help with reaching out to your legislature, your state representative and your state senator, so that they will know they need to support this bill. Now, with that being said, to give you a little bit more of an idea of how conniving these pharmacy benefit managers can be, one of our other organizations developed a study looking at Florida alone, just to better understand how these pharmacy benefit managers worked in the Medicaid system that's run by the state. And just in one example, with a generic medicine, they saw that the pharmacy benefit manager was paying a pharmacy that they didn't have a preferred contract with. They're paying this pharmacy approximately 20 cents a pill for generic medicine the patient needs to take twice a day. And they were paying a pharmacy that they had a contract with. Now you got to keep in mind, this contract that they have with the pharmacy is not accessible to the public. Why? Because it's proprietary. Well, they were paying them $10 a pill. And when you sit down and you look at things, it would not be reasonable, given the fact this medication is taken twice a day, every day, within a year, if you assume a reasonable number of patients are on this medicine, it's a commonly used medicine, very commonly used medicine, that it wouldn't be reasonable for there to be a $30 million discrepancy going into this preferred pharmacy's pocket. So that has caused a lot of uproar in Florida. That was not able to get this legislation passed, but it was able to get the governor to hire a nationally renowned actuarial firm to do their own study to validate and verify what this other study has seen. If there's that large of a discrepancy, then if it's the taxpayers' dollars, I think the taxpayer deserves to know, why is this pharmacy getting paid so much more per pill than your average pharmacy? Okay, that stuff needs to be known. There's been a lot of reform going on at the state levels because of little tactics like this, especially in Florida, especially in Ohio and Georgia. We want Florida to be next, and so we'll be reaching out to you to advocate more next year. We're also working at a national level in DC with a couple of different bills, a couple of pieces of legislation, one so that patients could get their drug within 48 hours, and they wouldn't be waiting several weeks or even months to get their medication. Now, some of that stuff's been put on hold because of COVID, but we plan on bringing that up at the beginning of next year, because right now, with the way things are in DC, not a lot's happening at all within the next several months because of COVID, because of the elections, but we are working on it as we can. So your involvement is essential. As I told you with the example, when it comes to healthcare reform, if your elected official hears about you, the voter, and they hear that you are concerned, they will listen. And we are planning on this next year, for this next 2021 legislative session, we are planning on having a bill introduced to help reform pharmacy benefit managers, but we need to have a coordinated effort, because there might be more than one bill out there. We want to make sure that you are sponsoring the correct bill. We want to make sure that you know why. So it's a good idea, I think it would be, if you are interested and want to help verbalize your opinion as a voter to your elected officials, that you put your name and email in the question box. Let them know you want the monthly newsletter. It's a monthly patient newsletter. That's one way to stay updated. Not only will you learn about advocacy issues, but you will learn updates about all the different things that we talked about today. And just as well, you can go to the website at www.patients.flasco.org to learn more about not only advocacy information, the things that I'm talking about here today. Once again, it's to make sure there's a coordinated effort so that you know when to reach out to your elected official, you know what to talk about, you know which bill to tell them they need to support, but it's also to learn more about other things for patients, such as assistance programs, various support groups, as well as clinical trials, and yes, of course, something important and dear to me, information about advocacy. And also, we plan on notifying all the patients that have participated in these Living with Cancer series when there is a time we need to call them to action, because you can help us, the providers, make sure that you have access to care that's affordable, quality, and that people are not taking all the money that's being designated for healthcare, instead of it going to the patients, they're putting it in their pocket. We got to put a stop to that. So I appreciate your attention, and please sign up for the newsletter, go to the website. Any questions, once again, please direct them in the question box. Your questions will be answered, but you all have a great evening. Thank you. God bless.
Thanks a lot for sharing that wealth of information, Dr. Diaz, and also raising these important points surrounding legislative efforts and advocacy, especially all that Flasco is involved with. If you'd like to be added to this mailing list for any advocacy updates, we would please request to submit your email either in the questions box here, or I understand that the time is limited, and also Dr. Diaz brought up about sending your emails and any of those concerns or horror stories, as he termed. Please send an email with that to info@flasco.org. That's INFO, info at FLASCO, flasco.org. So info@flasco.org. Please send in your emails. Flasco would love to hear from you. Once again, I'd like to thank our panelists for presenting this evening and leaving us with such a wealth of information. I'm pretty sure all the patients and caregivers are going to really appreciate that. After such a meaningful discussion, I'm sure we will all have learned something new that will positively impact our practices and patient care, and will leave our patients and caregivers with a wealth of new information. As a reminder, all of the handouts mentioned in this webinar can be found in the handouts drop-down box on your GoToWebinar panel. So please make sure to download them now. Additionally, this webinar was recorded, so if you missed anything and want to hear it again, it will be available at the Flasco website very soon. Thank you for joining us today, all the attendees and all the panelists, and we hope you will join us again for more webinars like this in the future. Take care.